he has a way of getting people involved. So what we decided to do is just to try and demystify some of the thoughts of various appliances. And Frank and I will just have a conversation, just a rapport as we go through the process of reviewing some of these devices. So we'll start off with sleep appliances. You know, we always get asked the question, how does it work? By moving the jaw forward, does it open up the airway from one perspective to the other? Scientifically speaking, even though some of the references are still old, it still holds true today. By moving the mandible forward, what you find is you get you try and prevent the collapse of the oropharyngeal tissues. And the intention here primarily is to open up the airway, but the dimension the airway opens up, interesting enough, is more from a lateral perspective than it is an anterior-posterior perspective. This is the most newest paper I was able to ascertain, published in 2022 using CTs. And you can see that they show that baseline on a responder, image number C, what the airway looks like in the habitual bite. The picture right opposing it on the right-hand side shows there's a significant lateral improvement in the airway. So when we take the mandible forward, it's not truly an anterior posterior dimensional change that's actually occurring. It's purely a lateral change that's actually occurring that can help open up these airways and manage these patients. Over the years, Frank and I have discussed many of these next topics, so we're just going to go roundhouse style and just talk about these various aspects. When you consider an oral appliance to manage your patients, what are some of the factors you should keep in the back of your mind? And the first one, frankly, is adjustability. Frank will give you information pertaining to appliances. Some different devices would have a different rate or frequency to be able to adjust. To make necessary adjustments when it comes to titrating the device. But also the other reason for adjustability is these devices last 3 to 5 years. And patients may have restorations that may be placed and things that may need to be done to modify these devices. So taking that into consideration as far as material choice would be one important variable, knowing that maybe these patients may have long-term care that may be necessary. Frank, I mean, I know we have thermoplastic in the lab. We have a whole bunch of materials. Is there any one material that may not be a good fit if possibly adjusting the device is necessary over time?
Yes, Dr. Patel. So, you know, in the image, you have the true Herbst. It's a Herbst style device, of course. It's Medicare covered if you treat patients with Medicare as well. And so the material that is in the image is actually a true comfort material. So it's a soft liner on the inside. So if you have a patient that you expect that will have restorative work, this probably wouldn't be a good choice material because the liner is really hard to remove and it's just hard to modify. So if you need it, if you know a patient is going to go through dental therapy of some type, restorative therapy, then you may want to consider an acrylic, possibly a PMMA, which is a digital version of this, and of an acrylic, and also, you know, possibly in some cases, lining the appliance with thermocryl, which is as you mentioned, Dr. Patel, a thermoplastic liner. So you would dip the appliance in hot water, the material turns clear, and it reforms to the patient's dentition. So those are a few material options that might work better for a patient that's going through some kind of restorative work.
Since we're on adjustability, what about acetal? Is there any limits, even though it's a nice fitting device, is there anything we should be mindful of with acetal type materials?
So acetal is a really great flexible resin. It's extremely strong. You know, the trays are typically about 1 millimeter thick. So it's very similar to a nylon material, if you're familiar with those. It's a great material to use for, you know, just about any case, but specifically if you have a low vertical case or patient that doesn't have a whole lot of oral volume, they need as much tongue space as possible. The downside to acetal, much like a nylon, it's not modifiable. So you cannot, you know, change the material to an extent. If it's a simple occlusal restoration or something like that, something simple, you can make adjustments. But if you're looking at a 3-unit bridge, you know, the acetal material, unfortunately, wouldn't, you know, be able to be modified. So we would consider doing something else. It won't bond to acrylic as well. So, you know, you can't really change the vertical per se.
Gotcha.
On
Gotcha.
acetal.
Gotcha.
Hey, Frank, in reference to tooth movement, is there an increase in the soft liner materials with tooth movement? Increased tooth movement in the soft liner materials.
Yes, so if you are concerned about tooth movement, I'll start with this, Trish, thank you. Oral device therapy as a whole, Dr. Patel, you might be willing to touch on this a little bit. With oral device therapy, there's always a possibility. There's ways that we can try to minimize the possibility of tooth movement, but it is one of the possible side effects. So just keep that in mind. But if you want to minimize tooth movement, you want to use a more rigid material. So again, PMMA, which is a digital version, it's basically a dense acrylic, and acrylic. The traditional acrylic are the two more stable or more rigid materials that we would utilize for appliances.
It's funny that question comes up now. I do have a slide a little later down the road talking about tooth movement, but since we're on that topic, we have a lot of dual laminate materials out there in patients, probably 3 to 5 years old. And we always educate patients that the life expectancy of devices are no more than maximum 5 years. So we kind of plant the seed. If you've done this long enough, you'll find that when you have tooth movement, it's probably more the material failure than the tooth moving for other reasons, because the device still fits. So they may have had decent occlusion at one point, and over a course of, say, 7 years, the teeth are flaring, but funny enough, the device still fits. So it's not that it's the tooth has physically moved, it's the limitation of the material over time that probably distends. And as a result, you get this slow progressive change that actually occurs. And to Frank's point, using these more denser materials, which are very resilient, you probably could minimize tooth movement over time. Now, posterior support always comes up. Most devices have some form of posterior support, and you should. And there's many arguments why one should have it and so forth. Some say it helps from the temporomandibular joint standpoint. And, we could go back and forth banter on it. But in reality, here's what really happens. In patients that are significant clenchers, you may find that they will wake up in the morning complaining of masseter or temporalis type pain upon awakening. And one of the biggest ways to modify that in this patient population is to add, I believe, a discluding element, Frank, on the upper aspect. And the reason why more the upper is it will extend out more buccally. And if you have to titrate the lower aspect, you're still on the platform. For some reason, some practitioners love putting it on the lower aspect, but if you put the element on the lower aspect, it has to go more on the lingual aspect. So as a result, you take away more tongue space. Frank, anything there as far as posterior support versus?
Yes, Dr. Patel, the majority of our devices are with posterior occlusion, of course, but there are options. If you plan to maybe have posterior support in the future, what you could do is request a discluder, as Dr. Patel mentioned. Maybe we can do a posterior stop that you can modify as needed, just a smaller posterior stop. If you want to have some kind of tripodization, where you can always relieve it, reduce the contacts, mildly. So that would be an option. But absolutely, we're happy to make with discluders. And I know that there are different sizes of discluders. So again, depending on your treatment philosophy and your comfort level, our traditional discluder is about 15 millimeters wide. It's in the front, basically the width of the centrals. But we can make more narrow discluders that are about 5 millimeters wide, or discluders that are canine to canine, for example. And that's more again of a treatment philosophy thing and a preference for the clinicians.
Yeah, and there
Yeah,
again.
with that,
Yeah,
a
sorry,
question here. If a patient has TMD symptoms and you suspect OSA, do you go with the MAD device or do you do a TMD device? If OSA is confirmed, how do you proceed?
That's a hot topic. I wonder if that's Anju's question, but regardless.
Dr. Deloli.
Okay. If you don't mind, let me deflect that towards the end if we have time, because there's different ways of actually approaching that patient population. And there's so many variables that need to be taken in consideration when you decide which way to go in that case. But if we just stay with this topic right now, as far as factors to consider, the other one's lip seal. And you got to be mindful about lip seal for one of many things. most apnea patients, what you're going to find is they have a big tongue as it is. And in some instances, you may have to give them more vertical, which is fine to do so. But the complaint you will get is they have a dry mouth upon awakening. Now, what you may or may not have identified leading up to treating these patients is, did they have a nasal issue to start off with? Which means, was their nasal component forced them to be more of a mouth breather, and with the excessive vertical, they dry out a lot quicker. So you want to be mindful as far as keeping your vertical as minimal as possible. Now, I do understand there's philosophies, once again, that some say more vertical is the way to go. Some say more protrusive is the way to go. And, we're not going to have that battle. But what we're going to say is, from a patient compliance standpoint, in some instances, try and keep vertical to a nominal amount, adequate enough to withstand the durability of the device, but also at the same time be thoughtful about trying to maintain a lip seal. But Frank, on that note, I understand there's so much thickness you need in a laboratory for appliances to last. If you can just shed some light on it.
Sure, Dr. Patel. For the majority of devices, let's say traditional materials, acrylic, for example, imagine making an upper guard and a lower guard, right? You're making an occlusal guard, so you're looking at about 2 millimeters of interocclusal space, per arch. So we're looking at least 4 millimeters of space, and we're talking about between the cusp tips, so intercuspal space, which technically may be more vertical than we think it is. So something to keep in mind. So when you're taking your bi-registration, just always, I recommend you're fitting a gauge, let's say a George gauge or tap gauge or sounding gauge, whatever. You put that gauge in the mouth and look in the back. See how much space is created. Again, for traditional acrylics, the dual laminates, True Comforts, typically we're looking at about 4 to 5 millimeters, a minimum space for appropriate strength of the material to allow it to last this 3 to 5 years, as you mentioned, Dr. Patel. Now, for other materials, the great thing is, for example, for nylons and for acetyl resins, we can use less. So we can go with possibly a 2 or 3 millimeter interocclusal space, which is really nice. For EMAs as well, for thermoform, we can keep the verticals lower if that's what you would require.
Yeah, no, that's a good point. So material choice, once again, based on what you're trying to achieve. When I jump the gun, titratability is the ability to advance the device. So when it comes to advancing these devices, what you want to look for is, what's the rate of frequency? In some cases, your dorsal, your herps, EMAs are pretty much straightforward, but you want to pick a device that has adequate titratability. Now, where you come into trouble with being able to titrate these devices is if you're very shy in getting a protrusive position, as an example. Frank, hold me accountable, but the herps rods are 6 millimeters maximum?
The maximum is actually 5, Dr. Patel.
5 millimeters. All right, I always mentioned at 6.
And actually, we are working on a Herbstrom that is going 6, so that's coming soon. Please.
5 millimeters. 5 millimeters. So taking into consideration, if you needed, say, to protrude someone additional, let's just for argument's say 7 millimeters to get them therapeutic, but you took a bite that was shy and you stopped them at 3, as an example. If we had 5 millimeters to that, you probably at 8. But if we had a situation where you needed to protrude them even further and you did not have the ability to do so because your initial position was a little bit more regressed, if I can use the word loosely, you want to manage that by realizing, if I use a specific device, how many millimeters will I cap out? And take that into consideration when it also comes to appliance choices. With the EMAs, the straps start at 21 and go to 13. So that gives you a good 8 millimeters?
Yeah, about 8 millimeters.
8 millimeters of advancement. So there again, titratability is something that you want to take into consideration. Mobility, not a major issue. Primarily all the devices, you'll find that there's some lateral mobility. If patients want to move side to side, let them move side to side. Do not keep them in a rigid device. I'll show you one rigid device here shortly that you could use in some instances, but just pick a device that has some lateral mobility. And I mean, Frank, I think all the devices that are in your lab have lateral play.
Just about all, Doctor. Obviously, the Herbst has about 6 or 7 millimeters of lateral movement. The EMA, of course, because of the elastics, has some movement as well. The one that gives us a little bit of a limitation is the dorsal design.
Mhm.
So the dorsal, we can create a little bit more lateral movement, but there's some limitation there. So that would be one to consider if you're concerned about lateral movement specifically. Now the upside is we have opening, so we got plenty of opening on the herbs dorsal. EMA sometimes tends to limit it because the elastics are holding the mouth together. But yeah, there's a few variables there on
Yeah.
mobility.
And then, of course, adequate tongue space. Trying to avoid picking a device that's extremely thick in nature. The whole reason why most of these patients have an issue is an inadequate tongue space. And then we add acrylic type devices or resin type devices to try and accommodate protrusion of the mandible. So we want to factor that in addition to the type of device we can choose, that what has the slimmest or the thinnest profile. Therefore, we don't have to sometimes over titrate just to kind of offset the thickness. But Frank, I mean, from where we are now with materials, I think there's really not much as far as a thick appliance like they used to be. What came to mind was like the silencer back in the day. They were pretty thick devices.
Yeah, I remember those, Dr. Patel.
Yeah.
Those were fun to make as well in the lab, by the way. We would have to invest them like the old school crowns. But yeah, for the most part, most devices now are 2 millimeters thick at the tray, the body of the appliance. And some, again, like depending on the materials you use, like for Panthera, which is nylon, or the acetal materials, you're looking at a millimeter thick tray, which allows for a lot of tongue space.
Yeah, no, that's true. So if we look at the synopsis here and just look at this from a quick snapshot, and we'll spend some time on some appliances here, you got pretty much 5 major categories when you classify devices. So let's just go through these 5 categories to kind of see what they look like. So monoblock, even though it may not be given a good, I guess, field example to use, it does not, you cannot titrate, you cannot add vertical to it. It has very little, if any, lateral movements. But what I do like about monoblocks, and this is where you like to use it in an instance where if you have a patient that's compliant on CPAP, but the issue is that their jaw props open and they're having to wear a chin strap. This may kind of offset both issues. By using a monotype type device, what you do is you hold the mandible slightly edge to edge, is typically where I'll take the bite at. And then you have these trays to kind of approximate the maxillary to the mandible, and then they just seal their lips across it. So you get an internal fixation type device to approximate maxilla to mandible. Even by bringing the mandible slightly forward, you're making some impact on tongue space, but you're not fully using it from a titration standpoint. I will say this, just from a clinical practice standpoint, it's a monoblock. It's typically just a splint. It's not really a sleep apnea device because you cannot really titrate it. So when it comes to how you try and bill for this, I just lean more towards a splint, a night guard, or something of that sort. But you can definitely use this as a service to patients that have situations where they are fully compliant on PAP therapy, but they have a tendency of the jaw propping open or air leaking, and their concern is just the fact that they have to wear this chin strap.
Dr.
You know,
Patel?
anything with bruxes, throw this in, and you kind of get 2 things taken care of at once, sort of a thing.
Sure. Question. Opting for a lingual-less option in order to gain greater tongue space, what might be the drawbacks or disadvantages to a lingual-less device?
Frank, I mean, I think I would say retention, maybe, depending on the type of teeth anatomy you may have, because you need friction to keep this jaw held forward, is my first thought.
Yeah, Dr. Patel, I think about, again, considering like partials, some of you that work with partials, it's always best to have reciprocal retention. So having support so that you can create proper retention. Overall, it's a great idea. You want to consider patient anatomy because if we require, for example, a patient doesn't have a lot to hold on to, and you have a lingualist assigned, then you're squeezing on those teeth a little bit harder than usual. So patient comfort may be a challenge there. So just things to consider. Consider patient anatomy. Of course, discuss it with your lab or your manufacturer.
Yeah. So when you look at hinge type devices, here's some good examples of the original TAP. Then we had the TAP 3 followed by the Dream TAP. Now, we talked about one of the variables being having posterior stops. So this is a device that typically comes to you without posterior stops, and you can add the posterior stops. But From a clinical standpoint, what's interesting about this device is you get a lot of tongue space, because if you look at the inter-arch distance between the upper and lower trays, there's enough for the tongue to laterally actually occupy that room, therefore allowing you to get a lot of usage from it. I do like this device. I would have to say I do now like the Dream Tap, the newer designs, from the standpoint that the screw was inverted. The mechanics is more on the buccal, not on the lingual, and therefore I'm not taking away, encroaching on tongue space. But this is definitely a device where if you have a person that's a significant bruxer, wakes up with morning temporal headaches, as an example, and they have airway issues, I may just consider this instead of adding a discluding element on any of the other devices. If I were to use this, it's already discluded on the posterior. Frank, anything on as far as this?
Yeah, thanks, Doc. It's a pretty popular design, of course, the taps. And the one thing to consider is the posterior stops. I know some clinicians like having, having the laboratory add posterior stops to these. Just consider the following, that when the patient's mandible is advancing, depending on their plane angle, their occlusal plane, they may, as they're advancing, there might be posterior interferences. So just keep that in mind if you are asking for posterior stops, to check the bite, because that may cause jaw discomfort for your patient, or dislodging of the device as they come forward.
Yeah, no, it's a good point. And I think also to add to that, if you're a fan of posterior stops, there's nothing wrong with it, frankly, excuse me, content words here. But if you take the jaw forward, once you get them titrated, go ahead and add the acrylic at that point. Because as Frank pointed out, if the lab places it and you are advancing this device, the occlusal contacts on it are not going to be the same as the original position that they're placed on. And you don't have to keep on monitoring it and modifying it. So if you want to add the stops, add them at the end after you've got the patient titrated to the point that the device is effective for them. The compression type device, the herps, I think this is one of the biggest workhorses in our practice. A lot of pluses with this device. Frankly, if you've not used a herps device, do consider using it. It does look medieval when you talk to these patients, but frankly, it works really well. You will find on occasion when they advance this device past the point of where the lower aspect is with the rod, I do have breakage or bendage that does happen. And I know we've got a case right now with you where this lady, I think this is the second or third time she's bent the rod. But I like your fix, Frank, where you suggested we just change the length of the herps so that it matches her protruded position. Because I understand they come in 3 sizes.
Yes, that's correct, doctor. So typically we use the medium herp storm, which is pretty standard for most cases. And then there are short arms for, cases where maybe you don't have a lot of protrusion, or the patient's missing a tremendous amount of dentition, maybe most of their posterior teeth. So they're the shorter arms. And in a case, as you mentioned, where the patient has maybe maxed out, the simple thing to do is to simply replace the medium arm with the long arm. So, they would just take over from that point.
Yeah, same thing with this. It's modifiable. You could add a discluding element if you needed to. I believe this can also come in milled PMA.
Yeah, that's correct. Yes. So this is a PMMA example here. The cool thing about PMMA, for those of you that have worked with it, it's just beautiful. It stays super clear. It doesn't tend to discolor like traditional acrylic, and it's stronger. I don't have the numbers, but it's definitely stronger and more fracture resistant than traditional acrylics.
Yeah.
Dr. Patel, in reference to back to the Dream Tap, the other Dr. Patel says that she has a patient in a Dream Tap from another provider that keeps opening her mouth at night, which dislodges the lower part of the appliance. What would be a better option, appliance option to make for her?
So she just opens the mouth while she's engaged in the device?
It says that keeps opening her mouth at night, which dislodges the lower part of the appliance.
I mean, the quickest fix is just put a chin strap on her, frankly, because the question is, why is she propping open? And if that's the only variable and she's been tested and it is determined that the apnea is under control, who knows why she's just mechanically opening up.
She said she tried chin strap and mouth tape.
She's tried chin strap and mouth tape
Yes,
and still dislodges it.
yes.
Question on nasal patency. I'm just wondering if patient is
No,
able to
that's
breathe.
definitely one. That's definitely one variable to take in consideration. I mean, there's got to be an explanation why she's propping open, but to prop against the chin strap, that's pretty powerful. I mean, when you're going through a sleep phase, you atonic, you don't have strength until you have an arousal. So you have to have some form of an arousal. I mean, I'm making assumptions here without knowing the full story, but maybe start off by validating, is the device therapeutic? Or is it possible it's giving her more apneic events? Because that can happen with oral appliances. We always hope that people get better, but there are a few cases where oral device may make the situation actually worse. I think a little bit more information would be necessary to decide what your next step is, but I wouldn't think another type of device, if we can't understand why the mechanics of why she's opening her mouth in the first place. So with traction-based devices, I mean, this is a very good, robust device. I mean, I think this is probably one of our top 3 devices in our practice. The beautiful thing about it, it separates, not hinged like the herps. It doesn't have like a rubber band like the EMAs, where you can put the upper tray in, put the lower tray in, and then you can just approximate the two. I've only had one fin breakage, but there again, it's probably poor case selection. But I do have this device in Brux's, and it doesn't break all the time. I mean, they are pretty resilient. The only thing I find that might be a limiting factor, Frank, and please share this insight, is when we have to titrate that screw, and we go to almost maximum to get them therapeutic. To me, it feels like that's the weakest link.
Agreed, Dr. Patel. Yeah, for it more so than a fin breaking, because we do, I don't know how many a year, but I mean, I could count on one hand. If we do thousands of these things a year, the fins are not breaking. What we have seen, as Dr. Patel pointed to, is once the screw is maxed out, it's 5 or 6 millimeters, then it, the screw is weaker, it's not as strong, it's not as strongly embedded in the acrylic. So that's when it can become a weak point. So it's something to consider when you're advancing, or you think that your patient is close to being maxed out. The laboratory can support you in resetting the device if you need for additional advancement. And there are always other ways. If you, as one clinician pointed out, doing arts and crafts, if you don't mind doing a little bit of acrylic work, you could add resin to the front of the screw or the back of the fin to help you to advance the mandible a little bit more. But there are ways to manage it. The key is to not allow it to fully, to max out, because that's a weak point for the dorsal.
I mean, just a little clinical pearl, if anything. What we've done in some instances is patients won't let us take it away from them once they're therapeutic, for us to send it back to a laboratory. And my fear, as mentioned, is that screws sometimes becomes a nuisance. So what we do is, where the screw hole is, we basically put cotton wool in it, and I take thermocryl beads, and I just flood the area, and I wrap it along the gap that's actually formed from the arch and the screw, and I just kind of reinforce with thermocryl. So therefore, in the future, if we needed to do anything, I can always put it back in hot water and strip it. I used to put acrylic, but I've learned my lesson that if you put it with acrylic and you lock it in and something needs to be done, it's almost like you buying the patient a new device. So using thermocryl or something that you can actually take back out is something we've been doing on occasion in instances where it seems like it's going to be the weakest link over time. Traction-based, I think here's another example of a traction-based type of device. This is your Panthera. To the point that it was probably the thinnest device in the earlier years, but now you have products like Acetal and so forth that are just as competitive when it comes to material choices when trying to pick a device. The only drawback I have with Panthera at times is it's very difficult to take those arms out. So a lot of times when we ask patients to do it at home, we end up having them come back into the practice to take those arms out for you to be able to titrate it. Vertical is an issue. You can't really do much with vertical there. Anything else, Frank, that you can share as far as this type of nylon type devices?
Dr. Patel, sure. There's obviously a bunch of benefits. The tongue space is maximized with this device, as you mentioned. very thin, extremely strong. I mean, the only times I've seen these things break is when a dog gets to it. That's really just about it. So very, it's a great device to consider. Another benefit is if you do Medicare, this device was recently approved for Medicare, well, a few months ago now. So you may want to utilize it for a Medicare patient. And then the only challenge with the traction-based device like this is retention. So just keep in mind where the connector is attached. That is the area where you're going to need to have good undercut on the teeth. You want to have teeth there to begin with. So, you want to make sure your patient at least has first molars, for example. And if they do have first molars and second molars, then you want to make sure that the teeth are not very lingualized or short clinical crowns that don't have much to hold on to. In which case there are other options, which is good.
Yeah, no, good. And then we have the pull-based devices, the EMAs. And I mean, the EMAs, once again, very robust. I like the fact that you have these straps that are easy to place. Really no negativity that I can think of right off the bat when it comes to EMAs. I know over a course of several years, we have transitioned to doing a lot more EMAs. The only one thing I find maybe a little bit of a nuisance, but it's something that you can get over with, is the fact that you may have to have inventory of straps. We like the blues to go out with the patients, but sometimes if it's too much of a pull, I will go ahead and switch them down to maybe the yellows. Very rare will I use the white ones from a rigidity standpoint. But there are instances I'll have patients with a blue, for example, and they stretch it out within a week or less. And in those instances, the clears do help, but they do still have to be replaced, but it's still better than nothing. Thin as well. And Frank, I think you've got a new material as far as the EMAs are concerned.
Yeah, Dr. Patel. So we have of course, a traditional EMA custom, and then next to it on with the blue is the EMA milled. So it's a digital version of the EMA. It's extremely strong. It's got some flex to it. So we did some trials a few years ago, if you remember, Doctor, and we I think had a few clinicians try them, and we got some really great feedback in terms of how it fit. It fit like a glove is what we were hearing. So it's really nice material. It's digital, which is really cool because let's just say the dog gets to the device. I mean, it can be reproduced. So there's definitely some pluses to it.
Yeah, and I mean, I think that phrase fits like a glove. I know who said that, but it definitely feels like it fits like a glove. And I use it on patients as well, because that's, if you've not experienced the EMA he's making reference to, it truly is extremely thin, very pliable, but yet very, very robust in many ways. And then we talked about thermoplastic lined materials earlier, and I do have a slide, and I like to just share this from one of many instances. Any of the devices that Frank makes, is there, I'm sure, the milled ones, the traditional designed acrylic ones, I guess acetal would be the only one where you would not consider this type of an option.
Yep.
Yeah. These are examples where you have a patient that needs to get a crown placed but can't afford the crown. So do we wait till the crown goes on, or do we manage the apnea? And these are instances where you want to kind of think it through, or that they need extensive dental work over a course of several years, but they were diagnosed with apnea. So taking in a device and asking the lab to put a thermoplastic lined material makes total sense. Just be mindful that you have to handle this material chairside. You never want this material to completely set in the patient's mouth, because I think this has happened, and it's a nightmare for everybody. And if you need some explanations as far as how to use this material, I mean, Frank's got enough years of experience to even how to trim it, work with the temperature associated with making it more conducive to fitting. And I do like it. I mean, the one time I really love this material is, besides the point of needing restorative work, is before we started scanning, we were taking impressions, and we would send impressions into the laboratory. And every now and then I'll get a phone call from Frank saying, hey, this impression is distorted. And you feel bad to bring these patients in when they come a long distance. So we were like, all right, go ahead and do the device, but please use this material. So when this would come back from the laboratory, we knew right off the bat that there was a bad impression. But what he gave us the opportunity is to put it in warm water and basically now remold it over the teeth and get a better fit. And therefore, save the patient the hassle, but at the same token, be able to have something that's a little bit more flexible in many ways and use this type of appliance selection or material selection.
Awesome, Doc. A
Anything
couple-
else, Frank?
Yeah, a couple of things is you know, this material we use the thermocryl material, and one use for it is if the patient has short clinical crowns and you know there's a lack of retention, this is a material we can utilize for that type of case. And so managing is, as you mentioned, doctor, is super important. So just consider if you have a patient that has a implant restorations, for example, and a lot of undercut or you know long span bridge or anything like that, you want to make sure you block that area out. Use some wax to block it out. And as Dr. Patel mentioned, when you're seating it, make sure it doesn't seat, you know, doesn't set completely before you remove it from the mouth. So if some of you are old enough to be my age, I guess, you know, when we used to make temporary crowns and you have to pull them off and put them back on before they set completely because you didn't want that material to lock in. So there, it's very similar. You just got to manage it properly. But it's nice stuff if you need to use it.
Yeah. So from appliance standpoints, let's be frank, you know, you are going to get changes in bite. Bite changes do occur, and the literature supports this. So the longer these devices stay in someone's mouth, the more the likelihood of a bite change from occurring. So your responsibility is what can you do to try and minimize it? So one thing you can do is make these morning positioners as an example. And by using these morning positioners, it gives the patients a point of reference of where their bite is. And you can get these morning positioners from True Function. And basically you put in warm water, as you've seen in this video, have the patient bite into the habitual bite, and then just run it into cold water. And it's basically a silicone type device to give you a quick reference point. So in the mornings, when they take the device out and do the instructions that you require them to do to reestablish their bite, they have a way to verify that they are back to baseline. All right, so you've got these morning positioners that one could utilize. Now, there are also these positioners that can be manufactured at the laboratory. Frank, you want to shed some light on these wonderful products?
Sure, Doc. This is a milled morning aligner, so it's a 3D version of it basically, and it's a more long-term morning aligner. So it's definitely not an option. Some of our clinicians order it along with their oral device. And so, yeah, please, you know, we can talk a little bit more about it if you'd like to try one out.
Yeah. So once again, to Frank's point, this is long-term. The other material, you know, if they run into warm water or anything of that sort, it will distort. This, on the other hand, will stay basically the same position from day one. The beautiful thing, if it's milled and they happen to lose it, you can always get another one manufactured. And the beautiful thing, you always manufacture to the original position. So you also have a point of reference of where were they when I started, if they disappeared on you, and you will see the type of change that may have occurred after several years. You know, using something that's a little bit more rigid would make sense. Lifespan, there's a couple of papers that talk about lifespan of oral appliances. Basically, what it boils down to, on average, it's about 36 months. So let these patients know that at about 36 months or so, it's going to be time for you to get a new device. The material is where the limiting factor is. There's a paper, there's a definition of life expectancy in the AADSM, and they used to use three years as the duration of a device. But after reviewing it, they've come to the point that, you know, sometimes 3 years or more should be adequate when it comes to life expectancy of these devices. So if we just switch gears for a second and go to occlusal appliances, specifically for TMD type of disorders, they basically fall into three major categories. You either have some form of a stabilization splint or modification of it, some form of a repositioning splint, and in some cases also a soft splint. But if we just look at classifications and see where everything has come from, you know, Okerson kind of talks about it. He talks about anterior repositioning or even the muscle relaxation appliances, such as the stabilization appliance. You have the anterior bite plane type devices. You have what they also call a pivot type appliance, and the soft resilient, which is basically a soft mouth guard type material. The only other place to get more information when it comes to splints is Dawson, late Pete Dawson's work. He talks about it from a standpoint of looking as a deprogrammer type of device, a directive splint or non-permissive splint, and then what he calls a pseudo-permissive splints, which are your soft splints or your aqualizers and things of that sort. So if we just put this aside and we kind of dig into this from another perspective, if you look at occlusion and you look at maximum biting forces, on average, it's shown to be about 162 pounds. And it does vary based on face type and a few other variables. But what has been recorded when it comes to bruxism, a bruxer can do about 6 times greater in sleep than a non-bruxer when it comes to the magnitude of force that's generated. So we want to take this into perspective when we select devices, because if we select in devices to kind of protect the dentition, but in some cases also to alleviate some of these symptoms, there are a few types of splints that one may want to consider. The far left is your anterior deprogrammer type device, where you have a platform on the anterior, and when the person occludes onto it, there's no posterior contacts. I believe, Frank, you also now have, I've seen your beautiful milled ones along with the original True Comfort ones.
Yeah, that's correct, Dr. Patel. We have quite a variety of materials that we offer for our devices, and milled is a very popular version. PMMA, which is super clear, and also acetal. So if you have limited vertical and you have a heavy bruxer, there's a really good chance they're not going to break the acetal. I haven't seen it yet. So, different material options. Of course, the True Comfort is a soft liner. It's extremely popular as well.
Then the second one that you see in the middle is your Farrar type appliance. This will be anterior repositioning in patients that have a tendency of locking in the morning. What you've got is a little teardrop type of a profile, so they can't retrude posterior when they sleep. Once again, you can have posterior contacts on this device, or you could have an anterior discluding element along with the teardrop to achieve the same goals. I always like to, when I'm using any one of these two designs, I always like to have a lower Essex with it, maybe more from a peace of mind to try and just keep the anteriors where they are, but not always necessary from a standpoint of usage. The last one is your stabilization flat type plane splint. This is your Michigan splint, your all the different terms to describe the same thing. But once again, you also have the flat type design that you may want to utilize in some instances. I believe, Frank, you also have, if I'm not mistaken, with the flat plane splints, you can do what they call like a dual arch, where it's flat on top and flat at the bottom. Two splints put together.
Doctor. Yes, yeah. So we can make a dual arch splint, as you mentioned. So if we've done a few where, if you need a patient to just be able to slide around and not cause any damage to the dentition. If you've had those patients that just wear out the appliances very quickly, that might be something to consider. Do you have indications of where you might use dual arch?
I mean, like Frank said, people have a chance of grinding down into these devices quite extensively and they destroy it. So if you put plastic against plastic, you're going to get a little bit more shelf life. Then you're going to have enamel against plastic. But the big advantage, frankly, when you have two flat planes against each other is it's balanced. Because if you look at a stabilization splint, you're going to have to balance it as best as possible. And that can take a lot of chair time. But if you have a flat against flat, then all the discrepancies have been taken care of because you now have it either digitally designed or manually designed. But the advantage here is you have no interferences of any sort. Now, I know there's different modifications that one may like cusp rise and things of that sort. And in that instance, you may just be looking at one arch with all those components built in. But if you're not looking from that standpoint, then there are other renditions that can be fabricated from the lab. And I know, Frank, you've been amazing when we've had clinical situations of trying to design devices because of certain situations. And there again, Frank is a great resource. If you have a case that's a little bit extensive and you want his input on maybe designing a device to offset what your requirements are, I think, Frank, it's good the service you provide.
And Dr. Patel,
Thank you.
we have a question of what would you use if a patient moves the jaw behind the Farrar, causing the mouth to open?
Yeah, so then what I would do in that case is I'll have like a lower Essex made, and I can have them put hooks on the upper Farrar and the lower Farrar and just put elastics to try and keep them approximated. The other reason might just be that teardrop is short. If they have a deep vestibule, just elongate that teardrop and that should take care of that.
Something we can also do is modify the angle of that teardrop, of the ramp, a little bit more angle to minimize the possibility of the mandible being caught behind it.
Yeah.
Changing the angulation. With regards to appliance design, our goal is obviously to take care of you and your patient and do the best thing for you from the beginning. So if we don't already work with you, and if we do, I'd love to sit down and update your preferences to ensure that we're doing what you're expecting to get. So we're happy to sit down with you and discuss your specific preferences for your appliances, and we can document that for you. Thank you.
And then you have a reposition split. A good classic example of a reposition split is either to determine vertical, if you can do a full mouth rehab, or you have a patient that has a clicking, popping joint, and that is the primary chief complaint associated with pain. You would determine where to put the mandible and have a device made on the lower arch so that they can function on it while you recaptured it. Another great example of using this type of device is if you have a closed lock and you're needing to unlock them, you want to use some form of a reposition splint. But there again, that's where the vertical element will come into play, how much vertical one might need to be able to offset that. But you have options when it comes to these types of devices as far as splints are concerned. I know you've got the ball clasp. I know you had the wire on the lingual to minimize it. There's so many different renditions. Anything?
Yeah. So we have, of course, what we call the compact. So if you get on our website, you'll see different variations of these devices. At the end of the day, they pretty much accomplish the same thing. They're made to your treatment position by registration, and that's extremely important for this type of device. Is that we, as a clinician, you provide us where you want the device to be built, or provided by registration at that ideal position for your patient. At the laboratory, I'd strongly recommend against raising vertical or creating it from zero, from centric occlusion, because there's just too many variables, dimensional variables, even at 1.5 millimeters or 2 millimeters thickness. There's just so many variables where the occlusal will be off, and would require a lot of adjustment for you clinically, and maybe a wasted chair time and maybe some frustration as well. So we strongly recommend the treatment position bite, and we absolutely offer different materials again, from the digital to the traditional acrylics.
Yeah. So there again, I like what you just said, Frank, and I'm glad you reiterated that point. You want to give the lab what vertical and AP you want. You don't want to send 2 models or a scan and say, you tell me where to put it. That's not really right. And there again, to Frank's point, there's too many variables where you'll be sitting chair side, grinding the bite in. So take your disclusion bite in the patient's mouth, send that to the laboratory, let them mount it to that position and fabricate it to the dimension you would like. And, it just makes it easier across the board. This is another rendition, a modified version of the standard anterior deprogrammers. What you got here is a flat upper with a little bit of a ledge, and on the lower, you have these 2 little buttons like. And the whole idea here is the same intention. You're discluding the posteriors, and you have very little anterior forces on the anterior force centrals. This came out of desperation when we'd seen some cases over time where we would get intrusion of teeth with the standard anterior deprogrammers. We've not really seen much complications with this yet, but this is a device that Frank does fabricate and something that you may want to consider. It is made out of the PMMA puck. And the beautiful thing about this is we've had many instances where patients have lost it or the dogs have gotten it, but then he's able to whip out another one in a very short period of time. Anything with this, Frank, that you know?
Yeah, so this is a Mira design, Dr. Patel, and it's pretty straightforward on our end. We do again recommend from the clinical standpoint to take a bite at an increased vertical. It's more like a passive bite. You don't need to reposition the patient. This isn't going to hold position, but what it does is allows us to make the device as close as possible to, as low as possible in vertical. Because if we're guessing on an articulator or a digital articulator, we may open the bite based on what we see. So if you give us a bite, we'll be much closer to an ideal vertical for your patient. Yeah, no, and that's a good point too. There is a modified version of it. We call this the Mira Plus. And this is an instance where you have a patient that say they lock in the morning or they have a clicking joint, and you do not want to use a Farrar type device. So I will use this with elastics. And once the joint is under control and the chief complaint's been addressed, we can just take the elastics off. Traditionally, what I would do with the Farrar is just cut the ramp off,
but there were some instances where I got in trouble where they would start locking thereafter, and I have to add the acrylic back. So in this instance, you just take the rubber bands off. If they feel like they're locking in, they can put the rubber bands back on, but it's supposed to mimic what a Ferrari does and also have the component of discluding the posteriors at the same time. And then we have the talent type device, a flat plane lower. Once again, indications can be one of many. Myalgia type pain could be used as a night guard. There are some instances where clinicians do not feel comfortable repositioning the mandible anteriorly, but yet with the talent type device, they let the mandible kind of float. And there's nothing wrong with that. It does work. You'll need to adjust it every so often as the muscles relax. The occlusion on this will change. So a talent type device can also be fabricated on the lower arch.
You know, the only thing I wanted to comment on this, Doc, is of course it's an extremely versatile appliance design. You can index it and do so many things with it. And also when it's digitally made, the occlusal surface is so smooth. So there's a lot less, you know, possibility of divots or contact points remaining. So if you're looking for a very, very nice and smooth surface, the digital versions are excellent. Really good choice.
Nice, nice. So with that, Trish.
Hello, I'm back. All righty, so thank you everyone so much for joining us this evening. I am going to put a couple links in the chat. If you do have any questions, or you would like to speak with Frank or let us support you in any of your laboratory needs, go ahead and complete the link in the chat, and that'll help you get directly to us. As for our promo codes, we are running a special right now on our EMAs that's running until August 4th. Now that is going to be 25% off your EMA as long as we receive it before August 4th. So that's next Friday. Our next webinar that we are hosting is going to be on August 30th, and that is featuring Dr. Jim Beck, and it's all specifically on treating TMJ and craniofacial pain with oral appliances. I'll also add that registration link in the chat as well. So if you want to register for that, you can go ahead and do that, and you'll get reminders, emails up until that time. So we hope you'll join us for that webinar. And then we'll also be emailing you a recording of the webinar today. So we'll get that out to you. It'll probably be early next week once everything is edited, and we'll send that out to you. If you have any questions, feel free to reply to that email as well. We're happy to get you connected with Frank or Dr. Patel. Other than that, if we have any follow-up questions, go ahead and put them in the question and answer box, and we can get those answered for you. And thank you so much, Dr. Patel, for joining us today. We really appreciate you.
Thank you,
No,
Dr.
thank you for having us all. And just to finish up with that question that you had earlier today. So when you have TMD symptoms, you suspect obstructive sleep apnea, you know, technically you're not treating the apnea until you know what they have. So go ahead and treat the chief complaints. There are some instances where you might use a device like an EMA, just use that as an example, but you cannot really bill it out as a sleep appliance because you've not had diagnosis yet. But you can use it off-label to treat a TMD condition, depending how you modify the device. If and when the patient does get diagnosed, then you can go ahead and just use that same device and just titrate it, you know, or just wait till you, so you still want to wait till you have a diagnosis before you start managing the apnea. But at the same token, you can at least get the TMD aspect under control. And I just want to share this last slide here. If anybody has any interest in reading more on these topics, there's a textbook that's out. Gary DeMargin in California, myself, and a few others have kind of put this together. But you've got some good information, good resources in these books, a lot of good clinical pearls as well. So feel free to, you know, consider getting a textbook and just spend the time understanding this topic a little bit better. We are open to take any questions if anybody has, or I know it's a long day for some of us.
If you have any questions, you can raise your hand and we can unmute you. Oh, I don't think anyone has any questions.
Okay.
Awesome.
Well, thank you guys.
Thank you, everyone.
All right, thank you, everyone. Like I had mentioned, the chat box includes the link if you have questions and want to connect with True Function. It also includes our next webinar that'll be next month on specifically the clinical topic of TMJ. So keep us updated if you need anything. Again, we'll be sending out that email, and you'll have until the 4th for the promo code for the EMA. So send that in before the 4th. Put the promo code in your notes of your RX or in DDX, and you'll get that discount. Thank you again for joining us. Thank you.